Guys, can we start?
Raz, dwa, trzy.
Okay.
Okay, please be seated if I may, because we need to move our conversation.
Hello, ahoj, dzień dobry. Nazywam się Paulina Nowak. Będę miała dzisiaj przyjemność
My
poprowadzić
name's
dla
Paulina
Państwa
Nowak,
debatę
and I'll have the
dotyczącą
pleasure
prywatyzacji,
to host
a
for you a
nierówności
debate on
regionalnych w
privatization
dostępie do
and
ochrony
regional
zdrowia.
inequalities in
Dwa ważne
access to
tematy, które się ze
healthcare.
sobą
Two
łączą.
important topics
Prywatyzacja, która
that
się
are
objawia w
connected,
różnych
namely
wymiarach. Od
privatization
outsourcingu
that is
poprzez,
manifested in different
kontraktowanie
areas,
świadczeń,
from outsourcing
kończąc wreszcie
to
na
contracting
współpłaceniu przez
services,
pacjentów,
ending
a
on
nierówności, które
co-paying
mają
by
wymiar
patients,
także
and inequalities that also have this regional dimension in all the countries of the EU. Today we're going to focus on these topics, and before we start the debate, let me introduce our speakers. Maria Libura, who is an expert in who's the head of the Department of Medical Didactics and Simulation at the Medical College of the University of Warmia and Mazury in Olsztyn, Deputy President of the Polish Medical Communication Association, and a member of Council of Experts with the Ombudsman for Patients. The second guest is Mr. Stajko, expert and representative of Razem Party, co-author of two reports. One of them is Initiative New Solidarity. Privatization of healthcare is a challenge faced by all the countries of the EU, and irrespective of the government, of the authority, of the political option that was at helm, this problem was present in different dimensions, and it was accompanied by the belief that the existence of a mixed market where the private sector is involved too, thanks to lower costs, we can improve quality of healthcare in individual countries at the level of communes and regions and the state. Now, let me ask the following questions. A question to Mr. Jerzy Przystajko and Ms. Maria Libura. So what's the situation of privatization of healthcare in Poland as compared to other EU countries? Well, it's a question about typology of systems, and according to studies carried out by OECD, and how the systems of healthcare are changing, and an attempt to find an answer to this modern typology without referring to models from the end of the 19th or the beginning of the 20th century, we can clearly see that Poland is in this quite unusual group of countries of Central and Eastern Europe, that also includes Hungary and Slovakia, are this low supply, low performance mixed system. So it's a unique group where we have quite high public outlays as a percentage of general outlays, but the structure of private outlays on healthcare is quite unique because usually it's the payment from the patient's own pocket. So yes, there's out-of-pocket payment, which constitutes quite a big share of this private payment. Now, there's also low focus on GPs and primary health care, and in general, there are low outlays on healthcare in total. So generally speaking, we are in this cluster of healthcare systems that includes the drawbacks of all the possible systems. And now it's not easy to leave this situation. Now the fact that our system looks the way it looks, is rooted in the times of People's Republic, of the socialist system, where doctors operated as part of cooperatives. So a combination of a practice in the public system combined with the private system and the individual flows of patients, well, this is nothing new, nothing that appeared after 1998 when we had the reform of the system. No, it has quite a long tradition. Now changing such a system is difficult. And therefore, doctors realized quite late that in the meantime, and now let me use the term of Dr. Lewandowski, a GP, that there's this that doctors don't work only in cooperatives, but they also work for big networks of healthcare providers, which radically changes the quality of care provided to patients, especially those who are excluded from this care in a way. I'm going to develop this thread on this privatization. So moving from cooperatives to, let me say jokingly, to the enclosure of the commons. Because this private operation of a doctor or a pharmacist who have their own patients and get some decent profit from it, that's a separate thing. And it's separate from all these conglomerates of pharmacies and hospitals and clinics, where this issue of profit becomes extremely important. And I would even risk saying that privatization as a notion itself doesn't paint us the whole picture. If you add to it privatization that covers big facilities and the issue of profit is extremely important, then it's quite erroneous if you expect that as part of such a model you're going to increase quality of service provided, because there's a limited number of patients and facilities can pump up their profits only by lowering quality of service provided, by lowering the number of medical staff, or by selling patients something they actually don't need. Health is the greatest motivation for every patient. People say that they never are going to save up when it comes to health. So people come to a doctor and the doctor says, okay, so you should have this whole array of tests, and the doctor usually says, you should get this complex one, but we can pay you for the basic one only. And usually patients go for this complex one. So here we have motivations where it pays off to make such small steps. And this is where these big facilities resemble big discount shops or petrol stations. So yes, it pays off to provide the patient with an additional test for which they're going to pay 20 zlotys, which isn't that much for the patient, but for this huge network, it generates profit. Now, when we talk about private facilities, it's hard to actually define who we are talking about, because we should differentiate between commercial facilities that operate for profit mainly, and they are motivated by profit and not necessarily quality. And we also need to remember about asymmetry of information. The patient cannot assess whether the treatment he received was good, the best, whether the results are satisfactory and beneficial to his health, and so on. So we can't use these models of perfect models of allocation of resources on the market. So yes, we should speak frankly about these commercial facilities, not necessarily private ones. Because in Poland, the majority of GPs work in non-public facilities, however, which operate as part of the public system and that perform public tasks. So when we talk about privatization, we very often spill the baby with the bath water. But the issue of motivation, this financial motivation, is important, because these facilities are often motivated by profit. And this leads to lowering the quality of services. And we have proof of that. There's this famous study concerning commercialization of certain services in Stockholm of paramedics. Now, the service providers, they actually showed better indicators for which actually they received extra money, and they ignored others. And in Kenya, for example, also because of this financial motivation, there was extra diagnosis of certain illnesses, because that simply paid off. So there was this. So yes, there should be this financial motivation that would actually meet the needs of patients, the benefits of patients. So yes, commercial facilities focus on profit, and that happens at the cost of quality of services provided. So the question is the following: what should be the role of different actors in this process? Now, I'd like to ask Maria about the central level here, and Jerzy, the question is about regional level here. What we need is good regulation. Let me share an anecdote with you. At the beginning of the 21st century, representatives of the Netherlands came to the National Health Fund to give pieces of advice on change, and they said, you know, you are this highly centralized post-communist state, so you need to deregulate a lot. But when they left when they were leaving after a couple of days, they said, no, you actually need some extra regulation. So there's this apparent centralization that we have in Poland. Even if we take a look at the reform of the paramedic system. So the general drive is that we should return to this state emergency service, that this should be controlled by the state. And what is the situation like? Yes, it is all happening under the aegis of the state, but then we have paramedics on B2B contract who operate as small businesses. So this is not what centralization is about. Neither does decentralization means losing control. No. We should provide control in an adequate way. We should regulate how services are provided to patients. So this is this overriding role of the state. And the mistake of the reform of 1998 was that we didn't appreciate the fact that the system that Michał Jamrus sometimes called the structural egoism, namely unsound competition, results in the situation where there are no mechanisms that would incentivize collaboration between service providers. Therefore, there's no continuation of care provided, because we can't speak about good quality care if there's no continuation of this care. Now, you can check the archives and the leaflets that we had at the end of the 1990s and at the beginning of the 21st century. And now we know that we have put the burden of looking for individual specialists on the shoulders of patients. So now you're going to be in control. You're going to look for the specialist on your own and make your own decisions, and the money will follow you. We know that it's not true. That was presented as a benefit, but now the patients, they can just decide which queue they're going to join.
This debate is a recurrent motive in the discussion on the system. So there was an assumption initially that the hospitals will be taken away from local governments, and this is also some kind of assumption. Let me draw your attention to the fact that we have strongly fragmentarized the system. So sometimes the outpatient clinic belongs to the municipality, and sometimes it doesn't. So it is the hospital that is located in the voivodeship city, and it belongs to university. With the previous debate, I really liked the concept that centralization is not a very popular term in Poland, but there was a term mentioned by Professor Gielerak about regionalization. So what is it all about? The level of management and the level of ownership that somehow coincides the tendency to collect all the subjects that operate on the level of the state in collaboration with the patient. So here the competition is strongly problematic, and the municipalities really take away some stuff from one another. These are unnecessary wars within the system because collaboration would consume much less energy. And regionalization, the level that makes sense, is the level of a province, of voivodeship. We are too little as a country to create 3 levels for management in the healthcare, and it will be difficult to imagine that these 3 levels will compete with each other. Also, there are some political issues. Local governments deal with hospitals, and then there are struggles on the part of hospitals whether to have one department or another, one ward or another, and this should end. The significance of it, whether we have well dispersed municipal hospitals or network of outpatient clinic. I do remember meeting in Głubczyce, which is in Opole region in the south, one of the poorer regions of our country, and there was a debate about the future of the hospital. A very popular subject, COVID pandemic, which resulted in a number of changes, and the patients, when the COVID patients were in the hospital and other patients were sent to other hospitals, and they were nowhere to return. Never to return. So what was the outcome of the competition? The hospitals kill each other. They compete against each other and not collaborate. So there was an issue. They will close the neonatal ward first. Then there will be no sense to carry out with surgery unit. Then pediatrics. And then the hospital will disappear. And the function of a hospital is a function connected strongly with the safety of a community. If we say, well, come on, you can commute to hospital 70 kilometers, it's far. People cannot imagine, and they want the region to be very well secured. And the system that is based on competition and not collaboration generates such dramatic situations. It's worth to depart from it, but we need the central reform for it, and the system of it on the level of a larger region with 16 provinces try to fill the gaps with providing medical services. Thank you. And now let's take into consideration all the territorial and regional circumstances. I would like to ask Maria about the access to specialist care in smaller towns, especially given the expenditures on the healthcare in Poland. So let me first of all clarify the question. So are you asking whether the access to specialist care is a problem, or the accessibility of treatment, or the continuity of it? Whether we ask about a question about the queue or the waiting time for specialist consultation, we have a large share of private investment, private expenditure, mostly on medication, and also Polish people pay for specialist visit or specialist consultations, and they can be present in various mechanisms. Either a patient gets a referral from their GP, and it suddenly turns out that the waiting time in the public system is very long, but also patients tend to choose some specialists for other reasons. So it's not the thing that the family doctor coordinates the treatment. Sometimes it is the outcome of the lack of confidence in a GP. So, for example, somebody thinks that my neighbor had similar symptoms, so she went to see a cardiologist, and that's why I should go. So, especially, it is the issue of people with very low health competencies, but also there is a similar tendency among well-educated people who are under the influence of the trends in alternative medicine, and they also have lower health-related competencies. But people who suffer from social and economic exclusion, the specialization of medicine leads to the lack of confidence in the family doctor, in the GP. So in the past, there was high confidence in GPs, and that is why the vaccination rate was higher. And if the family doctor is removed from the picture because he or she makes a part of the local community, and we install a seemingly equivalent system with a number of specialist doctors, we lose the level of confidence. This is manifested also in the fact that the family doctor is no longer someone that manages the case of a patient via specialist consultations and then takes over the care. Obviously, within the system that we are going to have some empty rounds. So, for example, if the patient does not pay for services, the system pays, because we have the asymmetry of information. The patient doesn't know what they actually need. So the family doctor, the GP, should really coordinate the path of the patient treatment and also take over the treatment decisions. In Poland, we have the Primary Care Plus program. So is it the direction that we should follow, rather than think what to do to shorten the waiting time for a consultation, for a specialist consultation? The patient should be appropriately treated in collaboration between the GP and the specialist. So it turns out that the discounting issue is significant, discounting of the primary care, because this might affect the intensity of the use of other levels of healthcare. So perhaps because of cultural reasons or historically rooted issues, we ask the wrong questions. Yes, let me add one more thing, one issue. We need to ask a question whether we need a specialist at every level, at every stage. The second question is about the empty rounds, so-called. We have a system in Poland in which the patient is circulating between various elements of the system. They go to the GP, and the GP orders the first panel of laboratory tests. Blood is drawn, and they go with the results to see the GP. And the GP says, well, we need to add more lab tests. So the patient goes to the laboratory and then to the GP. And the GP sends them to the specialists, and some additional round between the specialist and GP. And if there is one specialist, it's fine. But because of various circumstances, the patient's time is being wasted. They simply wait in queues only, and this is the situation in coordinated care. We try to shorten the path, and we do not need two doctors to order some laboratory panel or to refer for some task. And this is the option to be solved by task shifting, which is frequently proposed by the healthcare system. For example, in the case of laboratory diagnostics, if a patient goes to a laboratory, and we in Poland we educate a special profession of a laboratory diagnostician. We do have such a profession. Those people learn and have the competences to study the results of the lab tests and to realize to which additional tests should be ordered. So, and now one person is cut away from the long complex, because the laboratory diagnostician might suggest which tests should be added, and they are done, and the patient goes to see their doctor. So this is a significant problem in Polish healthcare system and also in other systems. So we waste a lot of patients' time and a lot of resources of the doctors because patients are resent all over. I will not continue because long contributions might also ruin the concentration among the audience. It's beyond all doubt that inequalities concerning also territorial scope do exist. So we said that we can shorten the waiting time, which is necessary both for appropriate diagnosis and for the duration of treatment, because we care for the good service provided to the patient. But also there is the problem of territorial scope. Some patients, for example, are unable to travel to see a doctor and use the medical service. So what can we do here? Can we connect or merge social services so that people who are unable to use them have a chance to have the access for them? Yes, this is an absolute necessity, because if there are plans for restructurization of hospitals, which have been mentioned for years actually, and it will be necessary to have a close look at communication exclusion of some patients, because it has really drastic outcomes. So, for example, patients from smaller towns give up some part of their treatment. And it's not only about the treatment, dental treatment, for example, which in Poland we have significant division between the cities and villages. So in rural areas, every 10th patient that turns adult has at least one tooth missing because of the problems with the dentition. So obviously it is an outcome of the removal of the publicly financed dental services, but also in the places where theoretically there is a consultation and dental consultation room in the neighboring town, but also we have the metropolitan concentration, which means that larger cities attract specialist doctors, which is also dictated by the way in which we motivate doctors to work. And on the one hand, the doctors concentrate in larger centers, but also there are some migrations of doctors to work on shifts in hospitals. So, for example, if you noted where doctors come from to work on duties in various parts of Poland, so a doctor who spends 2 nights on shift in Świętokrzyskie region, but they live in Western Pomeranian, it's quite frequent. Such cases happen. So the question is how to motivate doctors so that, for example, family doctors should also be present in smaller towns or villages. But in case of specialist visit, it's also the issue concerning the transport, which should be guaranteed by means of integrated services. But I would like to return to the previous question: why do patients circulate? It is also an issue of the price evaluation or cost evaluation, because sometimes they are so low estimated so that the diagnostic approach should be divided into a couple of stages. So for example, this used to happen in dietary support, but if the doctor offers a full panel of treatment, the practice loses their money. That is why it should be divided so that it pays off. So the method in which you regulate issues, so for example, whether a special tariff, whether a special price system affects the number of consultation visits and also specialist visits. All right. So the system of incentives for doctors so that they could address the territorial inequalities. But there is one more issue that requires explanation and further discussion, because this was really interesting for me during the contribution of the WHO expert, that we have shortage of staff and also shortage of some other medical personnel. And this is the question to Jerzy, whether there can be any solutions or systems of incentives to strengthen this system of healthcare. Yes. What has happened in Poland recently, and it is still the subject of a heated debate, is the issue in which you think of medical staff from the point of view of supply, not demand. So we have very few doctors, so let's open medical academy, medical college in every municipality, and they will be included into the system. Unfortunately, a wider picture is that we really lack a number of medical professions, and the leading role of a doctor is in our system so attractive that opening medical universities resulted in the fact that students from other professions were resent. So for example, in my profession, it's quite difficult to fill a year's presence at university. So a simple supply-oriented approach. So if we add, let's say, a bunch of doctors and another bunch of nurses is really not adequate. It's burdened with some mistakes. And also we here return to empty rounds. If we do various rounds for patients, we generate artificial demand for work, for labor, which is perhaps not very effective. Because if you have to do one thing a number of times, because otherwise it will not pay off within the system, or we do certain things a couple of times, we create the demand for doctors, we create the demand for nurses, for pharmacists, and also this shall be done perhaps in a more premeditated way, so that they should be done once and not a couple of times. And in that situation, the situation of the shortage of medical staff will be more balanced, that is more equally dispersed, in which we will see the real shortage of staff, which can be addressed from the point of view of the demand, because we will calculate the number of work which we really need, and then after the optimization and placement of various types of tasks and the responsibility within the system. And also let me add that we should remember about the revolution that was going on, so the implementation of various solutions in the scope of e-health, because this will affect also the demand among patients and the manner in which the doctors work. And also, once we try to integrate the solutions within the system, so one of them is quite predictable, so new inequalities will arise. So on the one hand, the internet is becoming the right of the patient, because you cannot use more advanced sensors that study various types of life parameters without very good access to internet. If you mention, for example, the databases that communicate some parameters, and then it's easier to manage the healthy patients. But we are at a risk of digitalization in two speeds. So on the one hand, the patients in larger cities with higher health competencies are able to use this solution, and the medical shop, let's say, would be something that is offered to the patients from smaller villages. So digitalization on the one hand gives a large chance to improve the processes, whereas on the other it might lead us to another division line. Thank you very much for the contributions, and now series of questions or comments from the audience.
Thank you very much. Thank you for interesting speeches. Let me come back to psychiatry or the mental health, because part of the debate in Poland about the future of the system also concerns financing. And this fee-for-service system of the National Health Fund, well, yes, it fits privatization, at least when it comes to doctors, because if I have my own clinic, I can work at a discount shop, but I can also get employed at different places. There I will get money for the contract, and in the end there's only the issue of my fee. If we know that this fee for service leads in certain countries to fragmentization, lack of continuation, and there's lack of incentives to create teams of doctors and to spend time discussing the problems of patients. Therefore, in case of the mental health centers, we fight for keeping the system that has been suggested, namely the capital budget, so that it pays off to build teams, to maintain teams, because maintaining a team means that a doctor is important, but other doctors are important too, those who represent different specializations. Such teams can include nurses, dietitians, lab experts. So maybe yes, this doctor isn't of such a key importance anymore, but he is still very important. So my question is the following. Well, we know that other solutions are possible, but we believe that this way of financing the system, which the National Health Fund doesn't really like, well, it may prevent the situation that we currently have due to privatization and its influence on mental health care. We know that when there's co-financing or fee-for-service, that is related to the contribution that you pay, then, you know, if you are poorer, then you will receive less money for the services in mental health care that you need. So if we come back to the fee-for-service system, it means the end of the reform of psychiatry in Poland. Okay, I'm a great fan of mental health centers, so let me add one sentence to it. The fact that it's happening in this capital fee system, that's one thing. What is important is that this mental health center takes everything under its wings. So when we have fee for service or fee per capita, when we have two different entities that are going to compete, will they compete to provide services or to have patients enrolled and then get this fee for capita? And well, there's a chance that this will work, because then we have this service provided in a given area and there's just one prince who rules the entire area. So we have regionalization too. So when we coordinate, when there's one facility that deals or covers one area and has a chance to create teams, and teams are extremely important, because when we have this structure of the system, when we have a kind of hierarchy or stratification, usually the patient is at the bottom of this ladder. But when we create circles, usually in the middle of such a structure, such structures, circles, they have middles, and in the middle you can put the patient. Yes, this fee-for-service mechanism causes the situation when the number of services grows. So we motivate people to increase the number of services. And yes, you can imagine areas where this fits the system. But this per capita fee, it can give a different result. Usually, when we enter a reform, it is started by those who are truly involved. But then, when you want to scale up the system, the question arises, what indicators should be measured so that we make sure that the process is of the good standard? But this shouldn't mean that we give up this budget mechanism once and for all. So what should we do so that these centers are accountable? Well, it's a very long process, never-ending process, because during the reform it turns out that certain mechanisms motivate people for something that they should motivate them to. Okay, is there anyone else who would like to ask a question or maybe share a comment? I have the following motion or the following comment. It's been a fascinating panel. Thank you very much. And I'm going to study further how this mechanism of services is influenced in Poland. If there are no additional questions or statements, then thank you to our speakers for your thoughts, for your proposals of solutions. Thank you for participating in the panel, and let me invite you to have lunch. We're going to reconvene at 2 p.m.
tunnel.
Okay.
We need to cut video for you for some time, but it's okay. We're still online, so don't worry
Okay.
if you lost the scene and lost your video perspective. If it works now, it will be working till
Yeah.
your Zoom, so it's fine.
As long as I get a clear heads up when I'm supposed to start and when I'm supposed to end talking, then I think I'll be good.
Okay, we have some strong delay, some massive delay. Do you have any limits of time? Because we start a panel, the next session at 2 p.m., circa 2
Okay.
p.m. And it's time for David Stason for presentation, and after that
Okay.
it's your turn. It's like 15 or 20 minutes after him. So like
Okay.
2:30 to 20 to 30, something like that. I will
Okay.
keeping you update all the time. But if it's
Okay.
if it's not okay for you, um,
No,
you
it's
can
fine.
oh, it's fine for you. Thank you, thank you for flexibility.
Look, Dorota, I completely like emptied my schedule because I was supposed to be in Poland right now, so
Oh yeah,
I have time.
yeah. But you're supposed to be maybe in in bed or relaxing.
Yeah.
Yeah.
I mean, you can maybe see I'm a little bit red, so like the allergy is not gone. It's the funniest conversation I've ever had over
Yeah,
Zoom.
it's
But
wonderful.
yeah, like I'm not doing great, but I'm good enough to do a
Yeah,
presentation, so that's
it's
good.
great to have you here, and thank you for your strong strength, and no, it's amazing that you made it.
Oh yeah, this is nothing compared to having long COVID and these types of presentations. So
Yeah, you're perfect example that this is an issue what we're talking about here.
oh,
So
definitely, definitely. Although, I'm actually recovered from long COVID, so
yeah,
it's really comparable. I shouldn't.
yeah, yeah. So yeah, but
Okay, so I have a little bit of.
other disease and other illnesses and allergies and so on, they are still existing. So happy for you that you're good good health after long COVID, and yeah, it's good to hear it. Okay, there's a one request. Can you play some music that we need fix this audio stuff here? But we
Oh, but okay, so I
it's
think it's best if I just talk
okay.
because
It's
okay,
okay.
so I have.
Okay, it's
Hmm?
totally okay, but we don't want to bother you staying long here online. So if it's okay for you, you can talk.
No, it's better to talk because I actually have a weirdly well-functioning noise canceling in my laptop, and so everything is filtered out.
Okay, okay. So
Like
let's do this. But
it's a it's a good thing, but it's also a bad thing. I mean, it's a
okay,
good thing because when my cat meows, like nobody hears it, but also I cannot do things like this.
okay, okay. So I will tell you when we need to some samples of
Of me,
noise
yeah.
and of sound. It's kind of weird that we're talking like that. I see you. I can see you right now. I can see a camera only,
Yeah,
and
yeah.
my
I
laptop
see you
is
just fine.
somewhere else. So this is maybe I take a
Oh.
picture for you and send you via WhatsApp what's going on here.
Yeah, I mean, I have to say the first picture was already quite weird seeing two people looking at my head.
It's our technical stuff. It's not like uh, the conference look like.
Okay.
Yeah, so I'm taking a
By the way,
picture.
I think the plant needs some water.
Uh, Definitely, yeah, this one. But it seems to have a good healing here, but yeah, maybe it's too much people for the plant. Okay, so I'm sending you two perspectives photo, and the second one is how I see you when I'm standing here. But it takes time because Wi-Fi here um, is weak for phones because all power is going to streaming and translators.
Ah, okay.
Mhm, mhm. Okay, so one minute break because we switch cables.
Okay. Can I quickly go to a bathroom?
Yeah, yeah, definitely. Take your time.
Good.
Okay, welcome back.
Okay. Well,
Can you can you say something?
hi. Yes, I'm here. Do you hear me?
Yeah, we can hear you.
Good.
It's sound mixing right now. What is happening here on us?
Yeah.
Okay, so keep talking, please.
Oh, sorry. Yes, I'll keep talking. Shall I just do my talk? It's 8 minutes. It's going to be very interesting. It's all going to be about long COVID and the amount of people that have been affected and how they've been affected and what we need to do to help them and all the things that you know from me. Please just ask me a question so I don't start babbling.
Okay, so maybe let me introduce you, David Stason. Come here, David. You are amazing.
Yes, David.
Our staff says some that, And please welcome on the stage David Stetson. It's your
Hi, David.
Hello, nice to meet you and see you. I think we'll be covering a lot.
Hi.
He told me just yesterday that I might have to do the whole talk myself, so I've actually got like 30 slides or something, so I can talk.
Oh my gosh, I'm so sorry. I should have sent you a message. Yeah,
No,
like
that's all
it.
right. I figured we'd end up covering quite a bit of the same info, so I'll be able to skip through some slides quickly.
I was asked specifically to talk about the long COVID community because I've been such a strong advocate and so connected and been such a part of connecting all these different groups from around the world. So it's quite a bit of a different talk than I usually do. I don't actually go into much of what long COVID itself is, but more about what patients need, how they've been affected, but also the type of compensation and financial aspects of it. So
I've got some.
I
I've got data on prevalence and economic impacts.
Good. So you're talking about all the things that I'm not talking about.
Great. Well, yeah. So I'm not really talking about patient advocacy so much, except my own personal experiences.
No.
What else are we covering? Yeah.
Well, I
some good
I
stuff.
would really like to hear more about your project actually. So maybe we should link up afterwards so I can hear more about that.
Absolutely. We're on this camera. Yep. Because I'm actually going to want to stand during my talk. Where are we projecting onto here? So it will be here. Right.
Good.
Okay, good. Looking forward to. I think
And is
Alex said I'll go first. Or
Alexander is just moderator, so he introduced you both, and you are the first, first starting the presentation, and after that Vicky, because she agreed to wait, despite of our delay. So thanks Vicky a lot for all patience. Um, um, a presentation. Okay, so thank you, Vicky. The sound is good, so we can disconnect
Right.
for now. You can relax or stay with us and hear what we are going to sing here.
Yeah, I will just turn off my camera and listen in
Okay,
and
so we are
hear till
online,
you get.
and I will keep updating you on WhatsApp maybe. And
Yeah, that's great.
okay, so thank you for that.
we begin next part? Okay. So I would like to welcome everyone on. Can you hear me? Okay, great. I would like to welcome everyone on in the panel of about long COVID. Let me introduce my guest. Our guest, David Stetson, epidemiologist living in Sweden, and there is with us online Vicky van der Dogt from Long COVID SOS and research aid development. We have theoretically 45 minutes. We must not prolong it. We will try to keep it shorter. Okay, and my introduction will be simple as well. We have 20 minutes for David to speak about nature of long COVID, about its scale, about its consequences, and means to mitigate, to prevent sickness. And Vicky van der Togt, after that, will talk about long COVID communities. We'll talk about her victory in Netherlands court. It's something very important for the context of well-being in workplace, and meeting and with team of Commissioner of Jobs, Nicolas Schmid. Okay, so let's begin. David, the floor is yours.
Great. Thank you very much, Alex. I wasn't sure how long my talk was going to be today, and I was actually up at 5 o'clock this morning finishing it, so apologies for any typos and other errors. Today is actually International Long COVID Awareness Day, by coincidence, March 15th every year. So on social media, you'll see quite a lot of activity about it. If you're wondering about my accent, by the way, I live in Sweden, but I'm Australian, so that's where that comes from. Now, this is a statement made by Dr. Elise Perago back in 2020. And we have lost the slides. It's back. The potential personal, economic, and social costs of long COVID are unfathomable. Unfathomable. That was said back in 2020. Why was it said back in 2020? Well, Elise was actually the person who coined the term long COVID after it became apparent that there were people not getting better after COVID. This shouldn't have been a surprise. 10 years after the SARS epidemic in Hong Kong, and it also spread to Europe, half of the people, the healthcare workers that had SARS, could not return to work. They were still ill with all of the same types of symptoms we're seeing today with long COVID. So the problem appeared very early in the pandemic. Now, what is it? You'll often hear, well, we don't know what it is. There's no agreed definition. World Health Organization actually came out with an agreed definition 2.5 years ago. It's basically, you've had a probable or likely SARS-2 infection, and you're still sick for at least 3 months, and then 2 months more after that, and you're not getting better. But what symptoms can it be? This is the problem. And there was talk in the earlier panels about the issue of different specialists in healthcare. Long COVID affects different people in different ways because this virus is not a respiratory virus. It's a virus that can get into every organ in the body, including, perhaps most importantly, the blood vessels, which means it can then easily spread everywhere else. So you can see on this graph here, we have it causing increases in diabetes, autoimmune problems. An issue called POTS is very, very common in long COVID patients, post-orthostatic tachycardia syndrome. Basically, their body is not able to control their heart rate and blood pressure. Blood clots, strokes, erectile dysfunction, decreases in female fertility, brain fog, fatigue, sleep problems, food problems. You name it, this virus can cause almost anything. The most common issues that most people notice are extreme fatigue and breathing problems. And it's not just fatigue where you feel a bit tired, and I'll come back to that a bit later. But what causes it? Well, leading theories over the last few years have been it's some kind of autoimmune disorder, and is probably related to myoencephalitis, so chronic fatigue syndrome. Blood clotting has been clearly demonstrated, particularly a thing called microclots. Normal tests don't show this, that actually are clogging the capillaries in your body so that the blood is not circulating properly through your body, and so oxygen can't get where it's supposed to be, whether this is your liver or your fingertips. So a lot of people with long COVID, you can actually see in their fingers and toes that the blood is not getting there. And the final one, which seems to probably be the root cause of the majority of long COVID, is viral persistence. We're not properly clearing this virus out of our body. Now today the only question is, does this happen to only some people, or does this happen to nearly everybody? And the evidence is starting to lean towards nearly everybody that has had COVID still has the virus in their body. The question is where and how well your body is controlling it. Now this of course means that what's it doing? Is it causing long-term damage? Is it going to reactivate occasionally and cause health issues, as we know happens with many other viruses like Epstein-Barr virus? We're also actually seeing viruses like Epstein-Barr virus, HPV. The presence of SARS-2 is actually causing those viruses to reactivate, which also causes additional symptoms. So viral persistence is appearing more and more likely to be what's actually going on with long COVID in most people. Now there are of course some people who ended up in, for example, ICU with severe COVID. It could have ended up with things like, it's called PICS, post-intensive care syndrome. And it's probably actually a different thing to what we're seeing with long COVID. How common is this? How common is long COVID? That's a really difficult question to answer because it depends on what you're looking for and how you ask. Are you talking about you've got any symptom at all? Do you have to have multiple symptoms? How severe is it? Is it mild? Is it affecting your daily activities, or are you actually bedbound from it? Now, I've met people that, a lot of people when they had acute COVID lost their senses of taste and smell. And I've met people that it hasn't returned after over 2 years and even longer. That's long COVID. But they'd never considered themselves to have long COVID. So if you'd asked them, do you have long COVID, they would have said no, but they actually do. Have you recovered? Or do you currently have long COVID? Different surveys and instruments that people are using to measure long COVID ask this differently. One of the top experts in studying long COVID in the US, though, he has noticed that everyone who tells him that they've recovered, when he asks a few questions, he realizes they haven't actually recovered. I'll talk about a little bit more about this later, but I had quite severe disabling long COVID for almost 2 years. I consider myself recovered, but I'm not actually. I can't eat beans anymore. This is a problem. I'm a vegetarian and I cannot eat beans. I get severe intestinal distress, heartburn, all these problems. If somebody sneaks beans into a meal and I eat it, I basically get no sleep that night. Did you have confirmed COVID, or do you just think you had COVID? A lot of different studies that ask whether, or try to work out how much long COVID is around, look at that in different ways. Is there a control group? Like, do you ask a group of people that didn't think they had COVID and a group of people who think they had long COVID, have you been tired the last few weeks? Well, everybody felt tired sometime in the last few weeks, so you ending up with a very small percentage of people who report long COVID when you subtract the two figures there. That's problematic. Most places have actually stopped researching prevalence of long COVID. We don't want to hear about it. We don't want to know about it. The US is still running what's called the Household Pulse Survey. It's been running for many, many years prior to COVID. Their most recent data report that 17.6% of people who believe they've had COVID report they're still having symptoms or have ever had ongoing symptoms for 3 months. 6.8% currently have long COVID. This was data from a few weeks ago. So you can see January to February this year was the survey. 5% their activity is being limited, and 1.5% significant activity limitations. Now those are high percentages, but in real terms, what does that mean? That means nearly 20 million people in the United States currently have long COVID. 4 million, it's severely affecting their lives. That's a lot of people. We can expect it to be much higher here in Europe because, obviously, larger population. So by the end of 2022, it was estimated that between 200 and 400 million people worldwide had experienced health issues, long-term health issues from COVID. That was the end of 2022. Then we let Omicron go wild, and many, many more people have been infected. You can affect, I expect it's probably over 1 billion easily. Now, if we're seeing this, people often ask me, well, if this many people were being sick from this thing, we'd be seeing it. Well, you wouldn't necessarily. If you'd lost 10 or 15% of your lung function and you weren't an athlete or someone trained regularly, you probably wouldn't notice, right? Athletes, on the other hand, have noticed, and there's a lot of athletes reported actually having to retire from professional sport and Olympic level sport because of what's clearly long COVID. But let's have a look on other potential factors. This is in May of 2022, so nearly 2 years ago. Falling participation in the labour market is not a lack of job opportunities, but a rise in long-term sickness linked to the pandemic. The issue of long COVID is very serious. This wasn't doctors saying this or epidemiologists saying this. This was economists from the Bank of England wondering what was going on with the recessions. And latest data now out of the United Kingdom, you can see on the right-hand side of that graph there, long-term sickness has been increasing dramatically. There's a lot of people out of the workforce. You're not quite seeing the same impact in the United States, but when you actually break down the data, you discover that they've had a huge increase of employment amongst new immigrants, where it hasn't happened amongst native-born Americans. So it's the immigrants are coming in and filling up the jobs. Here, closer to home, in Germany, I saw a report recently saying that the recession in Germany can actually be tracked to long COVID. That without long COVID, there would have been growth. With long COVID, it put the country in a recession, with more than 20 sick days a year for the average worker. When I was putting this together this morning, literally, I discovered the same report came out a year ago. 2022 data showed that the people were having, on average, 12 days of sick leave a year, and you can see compared to the average before COVID. Yeah, study, record sick leave led to recession. Now, in Sweden, we're also hearing it in schools, and we're seeing this the same in the UK, alarm from inside the schools. This is translated. Rampant after the pandemic. What's rampant? School absences. Now, they're trying to blame it on lockdowns. Now, it's not quite true, but the lower schools and middle schools in Sweden were operating to a certain level throughout the pandemic. VAB, that's vård av barn, or healthcare for children. In Sweden, if you're a parent, you can get paid days off at 80% to look after sick children. Oh no, they're complaining that way more parents are taking VAB. Now they're trying to say, oh, they got used to kids being home during the pandemic. But it's not. Kids are actually sick. The United States, there was a paper written by David Cutler and Larry Summers, who was formerly Secretary of the Treasury, I believe, economists. David Cutler had to update it a year later, and he estimated the 5-year cost of long COVID has been $3.7 trillion US in the United States. That's an enormous impact. Now, personal story. I was infected in wave 1 of the pandemic. I'd actually had visitors from southern Austria and a Malaysian guy who came to me from China, where he'd visited Wuhan. And I fell sick the beginning of March, right at the beginning of the pandemic. It was fairly mild. I kind of recovered, and then I started to get back into training. I was seriously training karate at the time and training towards my black belt. And I was on about the 3rd time I was jogging, and I almost collapsed. I just could not breathe. Then for the next 2 years, I was up and down. But I basically couldn't work. I had a startup in digital health technology. I had to shut that down. I had to lay off the employees. I couldn't get sickness benefits because nobody knew about long COVID. And of course, I'd come from a startup rather than a job, which complicates things. And for nearly 2 years, I was basically unable to do anything. I can remember once I merely spent some time cleaning the kitchen, and I had a lactic acid build up in my body that was so high so fast that I vomited. And I was one of the first people reporting that as a symptom, and now that's a known sign of long COVID. There seems to be some kind of mitochondrial dysfunction. Sadly, it hasn't just been me. These are my two boys, Dominic and Isaac. Dominic turned 18 2 weeks ago. Now, I've been recovered for about 2 years now, apart from the stomach issues I mentioned before. I'm back into training again with karate and living most of my life. Dominic got, actually our whole family got COVID in Christmas 2021 from a friend of Isaac's visited us. He'd been the only person in the house for 2 weeks. And he called us a few days later and said, "Are you guys sick? My grandmother tested positive for COVID and I'm sick too." And then we quickly all got sick. We all got better. Dominic did not. He was in grade 8 at the time. He basically couldn't continue school, and he hasn't been able to since. He's now doing distance education. But he tried to start high school, which he'd been looking forward to for his whole life. He had his whole life planned out. He was going to be joining the military. He went to his new high school and had survived 1 day a week for 3 weeks. Going to healthcare, nobody could help him. Nobody could find anything wrong. Same thing happened to me. Nobody could find anything wrong. Thanks to some doctors that have long COVID in Sweden, I gave pressure to his doctor to do some tests. And the doctor rang me up as soon as the test results came in and said, "Take him to the emergency department immediately." He had very high levels of indication of blood clotting going on in his body. And every single time he had blood tests for the next year, they basically called us and said, "Take him to emergency." They were worried he was going to have a stroke as a 17-year-old. He's since been diagnosed because we found a doctor with POTS that I mentioned earlier. His heart rate can go to 180 sitting at his desk. Once his smartwatch went off in the middle of the night and woke him up because it warned him his heart rate was too low. It had dropped under 30. Before he got on the medicine, his feet would go blue to black when he stands up because all the blood would rush to his feet because his body is not controlling his blood pressure properly. Now, Isaac has mostly been well, but we just noticed he keeps getting sick all of the time. And a lot of parents are reporting this. And a few days ago, I actually logged into the school software and checked his attendance since he started at the school. You can see the pandemic started halfway through grade 4. This is how often he's been off school. The last 3 years, he's averaged 40% of school days he's missed because he's been homesick. So, where's this going to go? Right. A couple of years ago, I wondered, well, if you roll a dice, if you roll it once, you've got 1 in 6 chance of getting a 6. But if you keep rolling the dice, sooner or later you're going to get a 6. So I did some simple mathematics on cumulative risk, like how likely are you going to get a 6 if you roll the dice 10 times? Well, how likely are you going to get long COVID if the risk is the same every time you get infected? Now, we don't know, is the risk the same? Maybe after you've had it once or been infected once, the risk goes down. Maybe the virus causes damage and the risk goes up. We didn't know, not when I did this graph, and it was very, very controversial when I did it. At that time, the CDC estimate was that around 20% of people who got COVID got some form of long COVID. So there's no serious level there. But you can see on that estimate that on the CDC estimate, after about 4 or 5 infections, the odds that you're going to have some form of long COVID, so you're sick for at least 3 months, actually exceeds 50%. Recently, Canada did some data, the first one I'd seen, where they actually looked at what's your risk of ever having a long COVID, depending on how many times you've had COVID confirmed. This was the result. You can see 1 infection, they came up with a 14.6% risk using their definition. To 2 infections and 3 infections, it went up and up. So how does that look? Well, I took that 14.6% risk, plugged it into my cumulative risk graph. That's the green line, and the orange dots are what they actually found. It almost matches exactly. It's there's no way in the world it's going to stay that way. Statistics doesn't stay that way. But it certainly indicates that the risk of getting long COVID is probably fairly similar every time you get COVID. Now, here's our problem. How often do people get COVID? Often people talk about COVID like the flu. Well, people get a thing called kind of like long flu. We know that happens, okay? The problem is people get the flu about once every 5 years or so. We often say we've got the flu, but we've got some other virus. This is data from the US, but I've seen similar data in Sweden that on average, since society opened up, people are getting COVID at least twice a year. Okay? So compare that to the flu of once every 5 years. This is from a colleague in Canada. They looked at, well, how many people are going to end up with long COVID, either from disabling long COVID, ongoing long COVID, or ever had long COVID over the next few years. And by 2026, you're looking at 1.2 million Canadians, it's a very similar population to Poland, are going to basically be disabled, unable to work because of long COVID. And nearly 10 million, over 9 million people will have had significant illness. So what can we do about it? Hopefully I've concerned you a little bit now. Well, I like to talk about what I call a Jon Snow moment. Not that Jon Snow. That Jon Snow. Jon Snow was considered the father of epidemiology. He noticed that everybody getting cholera in London, this back in the 1800s, seemed to be very close to a particular water pump. Now, at that time, people believed disease came out of a thing called the miasma. They didn't know about germ theory. But he figured there's got to be something going on with this water pump, and he tried to get them to shut down the water pump to stop the cholera outbreak. He failed, but eventually it did happen, and the outbreak went away, and we now know cholera is a waterborne disease. And we reacted to findings like that. This is actually from Chicago, where they literally raised buildings to improve the conditions of water, of both sewage, water provision, and still water. They were having problems with typhoid, they were having problems with cholera, all sorts of things. So millions of dollars were spent to basically ensure that waterborne diseases were no longer killing us. Now, we now clean our water to rid ourselves of these waterborne diseases. We are not cleaning our air. And what can you do? Ventilation. You probably may have noticed I've wandered around opening windows a few times today. Filters. There's a filter there, a filter there. There's another one at the back. These filters, they're only like a couple of €100, I think. They actually remove the virus out of the air. Indoor air quality monitoring. You can actually monitor the quality of your air using carbon dioxide buildup as a proxy for how much potential virus may be in the air. And I've been checking that around the room here today too. Far UVC is a new technology. There's ultraviolet light that will disinfect the air without damaging our skin. Masks, obviously. Masks work, okay? Don't listen to the bullshit, they don't work. They're a pain in the ass, I entirely agree. And I do my own kind of risk assessment. So I have a mask here, but I've checked and COVID is very, very low in Europe at the moment. You'll notice I was sitting over here near doorways or near the air filters. I wasn't sitting amongst everybody else. I was making sure doors were open and I was monitoring the air quality. Vaccination also appears to lower risk of long COVID by up to 50%. We don't know how long that lasts. Similarly, does having an infection protect you from getting long COVID if you get infected again soon? We don't know. The Canada data indicates not. Now, interestingly enough, there was a big push in Europe 2008 to 2013 on indoor air quality. They did a very, very large report on it. They did not mention pathogens, viruses, once in there. They were really talking about pollution and these type of issues. But they actually say that every European citizen has the right to indoor air quality that does not endanger their health. We now know that a lot of viruses, including COVID, are in the air. We can clean them. Ventilation is one of the ways. And the interesting thing is there's already laws on this. This is from Australia. Mechanical ventilation, this is the building code for commercial buildings and public buildings. It must control the accumulation of harmful contamination by microorganisms, pathogens, and toxins. Somebody said earlier about we don't need new regulations, we just need the governments to act on them. It's the same with this. We actually have this in our laws that we should be cleaning the air so that people don't get sick. CO2 monitoring. This is a little device I have here. Right now, 700. That's okay. 4,300 is what it was on the plane coming down. I had my mask on then. This gives you an idea just on the health effects of CO2. So 2,000 to 5,000, headaches, sleepiness, stagnant style left ear, poor concentration, loss of attention, increased heart rate, and slight nausea may be present. I really hope they had better air for the pilots than we had back in the plane. In the UK, they did an experiment. They gave HEPA filters into schools, and it cut sick days due to COVID by 20%. Masking, I use it in high-risk situations, if it's crowded lots of places and people. But if we do the other things, we don't have to worry about masking except in those high-risk situations, because nobody likes to masks. And you've got to do your own risk assessment. I go home to people who have to go to school every day and get infected. He's got less than 1% chance of getting infected if there's somebody here with COVID today. So, by cleaning the air we breathe, we can not only get rid of COVID-19, we can affect all airborne diseases. And a little known fact is there are 2 strains of influenza that are gone because of the things we did during the pandemic. We've eradicated them, and we didn't even try. That was by accident. Thank you.
Thank you, David. Now I will ask Vicky van der Togt to join us. Vicky, are you with us? Because we are not.
Yes, I'm with you. I can hear you. Can you hear me?
Oh, yes, and we can see you. Hello.
Good, good. Yeah, hi everyone. My name is Vicky van der Togt. I am a former long COVID patient, a patient advocate, and also a patient-led researcher from the Netherlands. I also work as a director of development at the nonprofit organization Research Aid Networks and as an expert advisor for the UK-based patient charity Long COVID SOS. I was supposed to be there in person today, but unfortunately I was hit with some odd allergic reaction and have been put on medication and told not to travel. And so unfortunately I'm not there with you today, but thank you for letting me still give my talk, but then virtually. Like I said, I'm a former long COVID patient, and I turned to patient advocacy as no one else was talking about this disease and these long-term symptoms in my country back in 2020. And by speaking out online, I quickly connected with other patients from around the world and eventually worked hard to connect long COVID groups from around the world over the course of the last 4 years. And therefore, I was asked to speak today about the international long COVID community, how it came to be, what patients need, and what they need you to know. So let me just get to it. In 2020, during the first wave of the pandemic, there were many people, including me, who got sick with COVID-19 and didn't recover. And fairly quickly, patients from around the world were noticing that, unlike what the government and health authorities were saying, they didn't seem to recover from their illness. And they started speaking out online on social media platforms, often because that was the only type of communication that they still had. They weren't able to leave the house, they weren't able to socialize, they were simply too sick to do so. And so having these online opportunities really gave them a way to still connect with people. As David already mentioned just now, Elisa Perego, an Italian patient, spoke out about her ongoing symptoms fairly early on in 2020. And she coined the term long COVID in May. Thereby, she made visible the persistence and heterogeneity of the COVID-19 symptoms, as well as that she gave patients a term to use for their ongoing symptoms. Now, more and more patients from around the world started speaking out about these symptoms, and they started forming patient groups and patient support groups to help and support each other, as there was very little help available for them, and they scrambled to really understand more about their disease and how to get the care that they needed. Many reported that healthcare professionals weren't able to do much for them, and oftentimes their symptoms were even dismissed. Patient organizations did get the attention from the World Health Organization, who decided in August 2020 to set up a meeting with patient advocates from around the world to get a better idea of their struggles and see what they could do to help. Fortunately, the World Health Organization did take their message seriously, and they were very eager to raise awareness for these ongoing symptoms of COVID-19 infection. But unfortunately, not many have followed suit. And that type of messaging from governments and health authorities from around the world is still lacking today. So since 2020, patient advocates have been fighting hard to get their needs heard. So what do patients need? Well, Long COVID SOS, the organization that I'm representing today, has three key aspects that they fight for, which is recognition, research, and rehabilitation. It's also their tagline. And I find that a good start, so let's start with recognition. Patients want governments and health authorities to acknowledge that COVID-19 has a wide array of long-term consequences and that these outcomes differ from person to person and in disease severity. Preferably, they would like their governments to actively educate the public on this. It is important that the public knows that COVID infection can have many adverse outcomes, including cardiovascular, thrombotic, cerebrovascular disease, diabetes, myalgic encephalomyelitis, or dysautonomia. But next up is rehabilitation, which of course is an important one. This is a difficult one because of the broad range of symptoms of long COVID. Those who only have a few symptoms may be able to be helped with physiotherapy, while this can have dramatic worsening of symptoms as a result for those who have ME/CFS type symptoms. There is little medical education on this, which leads to a situation where patients find it hard to find the care that they need. Oftentimes, doctors are also misinformed on the disease, and thus patients can get forced into rehabilitation programs that are unhelpful at best, but that can also have severely damaging consequences. This lack of education on the disease made for a situation where in many countries, patients have had to take it upon themselves to inform their general practitioners and other medical professionals about certain aspects of the disease. This was a struggle back in 2020, but unfortunately, it's still a struggle to this day. So patients, they struggle to get a diagnosis. Oftentimes, they struggle with being taken seriously, and overall, they still struggle with being seen in general. It needs to be said that there's currently no approved treatment or medication available for long COVID, but there are medications out there that can help manage symptoms, while I and many other researchers from around the world look for treatment options that work. And it's important that these medications are made available to patients as they have the potential to dramatically improve their quality of life, even if it isn't a cure for them. But next, I want to talk to you about ongoing risks. There really is a need to talk about the occupational risks and the financial aspects of COVID. Simply put, you can only get long COVID if you get COVID. And it needs to be said, especially in 2020, that there have been many essential workers who were ordered to keep working, sometimes despite being sick, often without any protective equipment, and many of them contracted the disease and subsequently developed long COVID. Now, many of these patients weren't able to get back to work. They had to reduce their hours with all the consequences of that, also financial consequences. And this resulted in that many patients struggled to survive, both physically as well as financially. Many countries don't have proper sick pay schemes in place, which makes it impossible for patients to stay afloat. Sick pay often also isn't enough to live off of for a long amount of time, and many struggle with obtaining disability status. And unfortunately, there is still an ongoing risk of COVID-19 infection. It's still going around, and little is done to prevent infections. And the result of this is that there's this ever-growing amount of people that are out of the workspace, and that this number will only grow with time. However, we know what can help to lower disease transmission. David Stetson just mentioned a whole range of preventative measures that can be implemented that would dramatically lower the amount of transmission. And all these measures should definitely be implemented in the workspace, but not just in the workspace. There's also a real need to implement these in public spaces as well as in schools. because long COVID doesn't just affect adults, it also affects kids. And this is not nearly talked about enough. But yes, children can get long COVID, and we must do what we can to keep them safe and to make schools safe for them. Now, some of these measures, like I said, David already mentioned them, but installing HEPA air filtration, ventilation, having CO2 monitoring in place, as well as keeping proper isolation, testing, and masking rules in place for if there are active infections are still good things to implement. By doing so, we can not just protect the health of the children, but also their teachers and other school personnel. Aside from this, I'd like to touch on the situation in hospitals, which is a big issue for many in the long COVID community. It is being reported more and more that masks are not even worn in hospitals anymore, and thereby this creates an unsafe environment for the most vulnerable who are in need of care. Protective equipment must be worn around long COVID patients or around COVID patients to prevent further disease transmission to medical personnel and other patients. Unfortunately, we hear more and more of patients who go into the hospital for a non-COVID emergency, but end up contracting the disease in the hospital, sometimes with the most dramatic consequences. Of course, this can all be prevented, and I personally can only say that I think it's a very logical step to at least have masking in place in hospitals. In 2021, I've helped a large group of healthcare workers in the Netherlands take the first steps to try to get compensated for not being provided with adequate protective equipment or the correct information about COVID transmission. This caused them to catch COVID at work, and they subsequently developed long COVID. Recently, and I'm really happy to be able to say this, these actions have led to a victory for them. And every healthcare worker that developed long COVID due to insufficient government handling in 2020 got compensated. They each got 15,000 euros, and there's been a specific fund set aside to compensate them of 30 million. I'm incredibly happy. Of course, they deserve this compensation. 15,000. It's a nice sum of money, but it's still rather small if you keep in mind that they have lost their livelihoods and they don't even know if they will ever be able to get back to work. Currently, a group of healthcare workers from the UK is taking steps to get compensated as well. And it needs to be said that both groups state that they followed government guidelines, but that those guidelines fell short in their supposed goal of protecting them or their patients. Now, the total cost of COVID, both economically as well as the legal action like this, it only further adds to the enormous cost of long COVID. And when looking at this overall cost, it's plain to see that the suggested investments to lower disease transmission will easily pay itself back. Now, I spoke to the European Commissioner for Jobs and Social Rights, Nicholas Smith, in 2021 about all these aspects of long COVID and gave a list of what patients need. But unfortunately, many of the struggles mentioned back then still exist to this day. And so it's time that we listen to patients. They deserve to be listened to. They deserve to get the care that they need. They deserve to get the support that they need, and they deserve to be compensated for being put in unsafe situations that cause them to become sick and sometimes even fully disabled. They and the general public deserve to be protected from further harm, and this means people need to be given correct and clear information about the disease and how to prevent it. Now, aside from all these obvious points, patients around the world call for more research funding to be made available to search for a treatment for this debilitating disease. Some even say that we need a long COVID moonshot, and I have to say I agree with them. I hope you all in attendance will work with me and the organizing partners to make this all a reality. Thank you for having me today.
Thank you. I would like to break with the tradition, and I have a question. Something like a question or comment, something like call to action, because of course COVID is a political annoyance, and not only political, it's a social annoyance. But as we have heard, it's not possible to just move on without addressing question of the air quality. And it's difficult to talk with politicians either on the right or on the left, even in social democracy, about these things, because of course there is a huge political risks about it, but not only risk in my opinion, but risk and political chances as well of addressing it. And so I have a question for our political guests and partners. What can we done to address this need for Jon Snow moment? Yes, as and David spoke about it.
Yeah, it's well, I've just
Yes, it would be good now, to raise those questions to European Commission, and of course, keeping in mind healthy workplaces. The healthy workplaces are very strong regulatory frame, which is just brought a lot of attention, and it would be good to now to raise those questions about situation. How can we improve working places, especially because it is up to new commission, up to new mandate to see, to draw attention, and to push forward all, to provide a report, to recommendations, to ask council to build some council conclusions, and then to encourage member states governments to see how they are addressing issues related to healthy workplaces, especially keeping in mind air pollution. Now air pollution is generally a very high topic. We pressed very much about environmental component. Environmental health now are closely interrelated. But environment means air quality. Air quality means, possibilities to monitor, to see, and to introduce necessary measures, especially keeping in mind, some places where people are working very intensive. I think that now is a very good time to raise these questions openly in front of European Parliament elections, and then speaking about new mandate of European Commission.
I'd just actually like to add something to that, because one of the things that's been happening in terms of building codes the last few years is the green movement, energy efficiency. And this has actually worked a little against health, because now we're blocking all the ventilation because we're trying to keep the heat in or keep the heat out. But there's already this movement of healthy buildings, which is taking into account both being energy efficient and looking at pollution factors. So all we're needing to really do is just add in one extra thing here. How about we look at pathogens as well as viruses and bacteria?
When COVID started, I was a big fan to propose a lot of measures drawing attention on ventilation, on CO2 measurement, on possibilities to introduce, ventilation system control, and so on and so on. Now we still to do the same. We need to continue. We need to press, because it is obvious. Obvious. We need to keep it, not to say okay. Now it's not, pandemic is over. We need to draw attention on other issues. No, we can especially keeping in mind evidence. Keeping in mind evidence, long COVID is based on evidence. We need to now to collect much more evidence and then present once again, recommendations. What can we do? When we can do? How can we do? Because now it's permanent issue. You have no chance to be like to say, to be not active in this.
Hello, good afternoon. My name is Mihai Kökény from Hungary, also a former politician, and you addressed, the question, how the politicians are thinking it's about. I think it's really an opportunity for various reasons, and we have heard that we still don't know enough. There is a lot of unrecognized, unmapped areas, So I think that, what we know and what we do not know about the long COVID and its impact on various sectoral matters, policies, labor, on health, on housing, on environment, or whatever you learn. That's really, I think, a good reason to advocate for putting health higher on the EU decision-making system, Because, as you know, neither in the Parliament nor, in the Commission, I would say health is there, but not as an independent portfolio. And then there's probably an opportunity that why we need to change. But I finish here because time is up.
Now the uptake of vaccination now is going down, down, down once again. And we need once again to encourage, governments to draw attention on possibilities, especially speaking about vulnerables, especially speaking about those people who are at risk, to continue vaccination. It would be now, it's timely once again to discuss about permanent vaccine programs, keeping in mind this long COVID syndrome.
Hi, could I respond? I agree with that last sentiment, which is that there's a real need to repair trust in authorities, in health authorities specifically, as well as governments. There's a lot of trust broken, as well as a lot of misinformation that is still going around on vaccinations that is having dramatic consequences. And we see that now, for example, with other diseases going around that we haven't seen going around this rampantly for a long time. I did want to add one thing, which is that what we often hear as patients is that there is very little known about this disease. But when you really look at the research side of things, this is actually one of the most well-researched diseases out there now. I personally, with my organization, we keep a research library, and we have a vetted library, which means that a lot of them don't even end up in the library. But our research library already consists of over 2,700 research papers into long COVID, but I know other libraries that have over 5,000. And so we cannot say at this point that we don't know enough. Now, with that same sentiment, it also needs to be said that we also keep a research library into the efficacy of masks, as well as the effectiveness of air filtration in filtering pathogens from the air. And so with this, I just want to say that the research is out there. It's just time that we actually implement it.
Okay, thank you for this discussion. Thank you, Vicky. Thank you, David. And I'm counting on continuing this conversation after our conference.
Thank you, because we continue actually discussing on what the European Commission should do, particularly in this panel on the European Health Union. And let me invite immediately my guests. We will have only male in this panel, which is a pity. indeed. First of all, let me invite Mihaly Kokeni, that was just speaking now. He's now a lecturer at the University of Debrecen, but hold important position in Hungary as a Minister of Health, and also one of the co-authors of the book on by FEPS on the European Health Union. Thanks for being with us. Another former Minister of Health from the Czech Republic, Svatopolok Nemeček, please join us. After your time at the ministry, now you are much closer to Poland as well, because you are president of the board of the municipal hospital here in Bohumin, which is not that far away. And then I'm very happy to have here with us also Nicolas Moravec. Please join us in the panel. Nicolas, and I'll actually start with you, Nicolas, telling also to the public why we strongly wanted you here, because you are one of the citizens that took part in the European Commission exercise on the future of the European Union, the conference on the future of the EU, in which several citizens have been randomly selected to participate in panels to check, okay, what do citizens want from Europe? You took part particularly in some working groups dealing with health, and you have also responsible, together with the other citizens, of this long report with many recommendations. And we have discovered that the citizens of Europe are a little bit more progressive than their governments. So we really would like to hear from you what was this process a little bit, and what are the recommendations on health that came up in this discussion.
I will be speaking in Czech. Takže ještě jednou já vás všechny zdravím. Ano, ten proces probíhal.
Welcome once again. I will be speaking in Czech. This process was going on in the way that initially it seemed very simple and easy. So there were 200 EU citizens selected. They came to a session in Strasbourg. I worked in the health panel, and out of us 20 ambassadors were selected, and every month we flew to the plenary sessions and we discussed with politicians and experts, and our panel presented a number of recommendations. Let me name some of them which are most interesting. So as one of them concerns dental care, because I believe that it is not a problem of only the Czech Republic, but the problem of the whole European Union. So we spoke about it, that the dental care should be available for everybody between 15 and 20 years of age, and some investment should be made in this area. So it shouldn't be like that if somebody cannot afford going to a dentist because they have no money. So when we are looking for a dentist, we will not be able to find anyone because there are so few of them, and the health requires the presence of teeth. It's obvious. Also, we said that COVID has shown us what it should not look like, because the European Union within some other regulations should have larger competencies, because, for example, in France, the person was vaccinated and the certificate was valid 14 days after vaccinations, and in Czech Republic 21. So the EU should have more competences concerning it in case another pandemic arrives. We also spoke about health and food, so we should supervise the administration of antibiotics to animals, because numerously we say that something is tasty or not, but we don't know whether this is tasty, or perhaps it is because of various types of additives. That is why I believe that we as citizens were very strongly involved in this debate, and we are struggling very strongly.
be read in a FEPS publication, and it was not surprising. I will quote just some results, very, very few, that more than 70% of the population agreed with the strengthening of the European Health Union. Even more than a third of the strongly sovereignist voters of the ruling party even. There was also a unanimous opinion regarding the fact that much more needs to be spent on healthcare. And as far as the medical and healthcare organization, we also had an online interview with a couple of them, and then there were several questions. And then, for instance, one of the questions was that what are the areas in healthcare where the current nation-state competence should be shared with the EU, and 46% of respondents mentioned epidemiology, of course not surprisingly in times of the pandemic. Then more than 20% of respondents mentioned public health. Rest of the responses covered a wide range of topics, and an issue of universal health coverage. Is there a need for instance, a European directive to guarantee universal, non-discriminatory access to publicly funded health services, etc., etc.? More than half of the respondents said yes. And last but not at least, that it is interesting that the Hungarian specialists, doctors, found that the compulsory childhood vaccination to be better than in the EU in general, in Hungary. So they wish to continue the domestic practice here, and then they were happy. And it's a very few of the areas where probably Hungary still keeps a type of level, and in this case they didn't want more European intervention in this field. So it was quite an interesting survey, and I am very sorry that other countries have not followed that initiative. And maybe if we will have some further debates, there should really be more research about this, because together what we have just heard from the citizens' voice, Svatopluki for me, it's so important, you know, to know that what people really would like to see. This is something you just cannot rely on, you know, your political experience.
Thank you. A similar question to you, President Nemecek. What is the role of the EU? Because you have been leading health policy at the national level, now you're doing so at the local level. Do you see angles where you would really appreciate the European Union stepping up, where they can help in just financing, setting standards, you know, regulating pharma? What would you be? You have a microphone in front of you.
First of all, I want to say I'm delighted to be able to participate in this meeting right here in the region where I live, even though it's on the other side of the Orza River. So I see the area when we should manage healthcare politics in European level in two areas. We have all experienced the COVID epidemic, which has shaken for certainties in many ways and changed the world. We knew it before. We found that globalization ceases to function in such turbulent times. Initially, we liked masks. There were problems with vaccines and some medical supplies. And now a few years have passed, and we should ask ourselves if we are better prepared for similar situation. And for example, in Czech Republic, in my country, the government politicians boasted about building a strong national center for epidemiology and microbiology, and yet they did nothing. And I'm not aware of any progress at European level. And I am sure that infectious disease and the public health in general must be addressed at the European level. I think it's the first area that we should solve at European level. And another such area, I'm sure, is the production and distribution of drugs and medical devices. I think that we need to bring at least part of it back to Europe. And it's also clear that individual member states, especially the smaller ones, do not have the strength to negotiate on equal terms with multinational pharmaceutical giants regarding the condition for strategic drug supply. So at first, I should solve these two areas on European level. Of course, we can cooperate in many areas. We can exchange information, experiences, successful solution, but there is a problem with financing of healthcare and organization, and I think it will not be in very short time. But the first areas I think we should solve.
Two good suggestions indeed. Professor Kokani, let me come back to you, because you've been able to work with the European Socialist, Istvan, and many others, to also try to strategize on the different building blocks, policy areas that constitute the European Health Union we want. So perhaps can you take us a little bit on what should be the components of this European Health Union? We mentioned something, but sure you can add more.
Well, I think in the previous session, I think our epidemiologist has mentioned Jon Snow's moment. Jon Snow is a famous epidemiologist, who discovered, that what could contribute to the cholera epidemic in the UK in the middle of the 19th century. And now I would like to say that probably just right before the European election, in terms of health policy and in terms of the competencies of the European Union in this field, is coming close to a cosmopolitan moment, if I may use this type of expression. I think it's a special moment, because we know a lot what has been done and what not has been done. We know a lot on, what could have been done better during the pandemic if we would have much more power for the European Union. We know a lot. We are listening, to coming some voices from nationalist forces who just think that health should really be a symbol of sovereignty of the member states. European Union has nothing to do with this, which is terrible to hear. So therefore, first of all, I suggest that we need to talk about openly, and we need more public debate. We should speak much more about health, because that affects every citizen in the European Union. But my problem is that I can't hear so many voices about it, at least so far during the election campaign. So more talk is needed. National governments, insurances, patient organizations, public health people, etc., etc. What should be done? And I believe that there is a completely legitimate need, as we have heard at the beginning of our conference this morning from Vitenis. It's a completely legitimate need to supplement the treaties and classify health issues as shared competence in the EU. Yes, however, we should be aware that we should fight for this, but in the meantime, we have actions, because the time frame are different. of course. So there are a lot of other things to be done. And then let me just mention the inequality issue, for instance. The inequality, we all know that if you think Eastern European countries, if you compare it with Germany or France, and whether you think about, the nursing supply, the health workforce situation, if you just think about the health indicators, if you think about the various health determinants, or if you think about, the public spending on health, which I already mentioned, there are so many unacceptable differences which could lead to inequalities in access to care, which is also morally unacceptable in a unifying Europe. And that's why I think that, for instance, we often talk about the policy, health policy minimum standards and the requirements are concerned. And this initiative was raised by the public health strategy of the European Parliament at the outset of the pandemic in 2020, and not because of the unpreparedness of health systems and the societies, but because of witnessing that there's so many unjustified inequalities in health and in access to care. And these inequalities interfere with the implementation of the cross-border patient rights directive, but large differences in many other places. So, I think that after adequate testing, basic requirements for these must be developed and introduced. I, of course, know that these minimum standards are not grounded at the moment legally in the European Union. But still, if they do exist as recommendations, they may serve as a target model for the future. So I think that could also be an important thing. And then, of course, if I may add one more thing, I've already mentioned some part of it. We need a new period, a new next 5-year cycle in the European Union, where health policy is much more explicitly reflected in the structure of the EU decision-making. I think about the independent health council configuration. I think about a separate health committee in the European Parliament, not merged with the environment. And last but not at least, independent portfolio, eventually even a vice president position in the European Commission, for instance, vice president for health and well-being together. If we should talk about this more honestly, what should be done, how should be done, how we should achieve. Of course, there are many, many more, but I stop here. Then, of course, something might happen.
It sounds like a comprehensive agenda, and I like also the governance suggestion, because it's not only about the policy that we want, but it's also how we organize the decision making. So, European Commission on health and well-being, I think it could be definitely a good way to go. But let me go back to Nicolas, because we discussed as well before about mental health. That's definitely a pressing issue for youth. The Commission has moved, thanks to the pressure of the general public and citizens, towards a European mental health strategy, as we discussed a bit. Do you see any hope there that the institution can respond to the needs of the people, or would you have other recommendations?
Já děkuji za slovo. Tady dneska už několikrát zaznělo, že duševní zdraví je tak trochu horké téma v dnešní době. Pro nás, jako pro mladé nebo pro moji generaci, já hodně vidím v okolí, že prostě skoro o ničem jiném moje generace nemluví. Jo? Tady je obrovský problém v tom, že spousta těch mladých trpí nějakým problémem a Oni se bojí vyhledat tu pomoc, jo, protože já to znám od mých známých, co mají nějaké také problémy. Oni se bojí docházet k tomu doktoru, jo, protože teď si řeknou, půjdu k tadyhle psychologovi nebo k psychiatrovi a teď ze mě tady udělají prostě nějakýho blázna, řekněme, jo, říkám to tak, jak to moje generace říká, jo, omlouvám se, tak to samozřejmě není, jo. Za covidu prostě, jak jsme byli doma, nebyl kontakt, tak tady ty duševní problémy se prostě hrozně rozvinuly. Takže já věřím a doufám, že Evropská unie
couldn't socialize and therefore mental health issues developed. I believe that the European Commission should come up with a pan-European solution. And I know that this problem is universal all over Europe. Another issue related to mental health is that young people, instead of turning to professional help, they become addicts. They turn to different substances. And in Czech Republic, we know how greatly people are addicted. And despite campaigns raising awareness with this regard, there are still more and more people who become addicted from different substances. So we should make sure that people look after their health instead of turning to addictive substances.
Interpretation to end. Thanks. But good. That is the important stuff. President Nemeček, I come back to you with a difficult question. Actually, probably my last. If you have more, we can try to take them. Because we've heard how much health is affecting citizens, how much they need a different and more affordable and more present support on mental health. It's literally a pressing issue. At FEPS we also run statistics and opinion polls on the youth, and even the young people, they put health as a top political priority. How can we not win elections on health? This is the somehow. So how to popularize or politicize the debate a little bit more? At the European Union level, for instance, it was the center right that was telling to member states, cut on health to save your public finances, and then of course COVID came as part of the austerity, for instance. Why the progressives in general, center-left, social democratic coalitions that are historically for strong public sector and health, we are not gathering more support? How we can galvanize here in any where you want, like popularizing health and winning with health, getting support.
I don't know because I think we in Czech Republic, we are in the opposite situation, because I think in the last 10 years we have really very high level of the quality of the healthcare system, and this very low payment of people. And now we are in the point where our system is starting to going down. Now to the healthcare is in healthcare we have more money than in the last years, but the quality is stopping, and I think then the system will go down. We have a problem with demography, in the patient sphere, but this demographic problem in healthcare professionals. For instance, in Czech Republic now, the 1/2 of the general practitioners are older than 60 years, one half, and about 15% are older than 70 years. So I think that we will have a great problem with keep the quality of healthcare in our country, and it's very strange that there is no debate about healthcare in Czech Republic. Nothing. The minister from the right-wing coalition now is making minister, but he's nothing. He's doing nothing really. No, every problems are going further, and for people it's not a theme. Maybe the only theme where the availability of the dentist care in Czech Republic, but I think that the same problem will be in 5 years the problem with general practitioners. So I don't know how to manage.
If I may add, although you have not asked me, as I see, again, to put health higher on the debates with the public, I think we should focus on issues that affect people in the day-to-day practice. So doctors are very important, nurses are very important, but when there is a debate, we should not professionalize it very much in public. We should, start what are the problems of the patients, that why they should wait for a cardiac ultrasound for 6 months, These are concrete examples from Hungary. Why it is that if you have an orthopedic problem and then you are offered surgery with your knee for 3 years waiting time, 3 years at the moment. But if you go to the private hospital, then of course you pay a terribly lot of money, in addition that you pay for your insurances as well. Then you will be operated within, 6 weeks or whatever. So why it is so? So I think these issues should be openly discussed together with the patients, together with the media. We should put good podcasts, use the social media. I think this is not really well utilized. And I think probably the progressive forces, the European socialists, should take it even more seriously, I would say, because I see that I mentioned the inequalities, the huge differences in access to care or whatever you talk about. These are not really well addressed, even in the PSC documents as well. So I think that's probably an entry point.
Thanks a lot. I will go back to Brussels with this idea of putting in the European Health Union as a minimum standard of maximum 30 days waiting period for a medical exam. That's what Progressive wants, to be precise. Now, please help me to clap your hands to thank our speakers, in particular Nicolas Moravec, who has to leave us. Actually, have to catch a train. So I'll free you. We do a little bit of a switch. We say goodbye to Nicolas, and I invite here instead on stage the Chief of Cabinet of the Deputy Prime Minister, Konrad Golota. If you can join me here, so we do the conclusions with you and with the former ministers. Thanks, Konrad. Maybe I can give you the floor, and you prefer to stand, perhaps, because you have this ability of representing, in a sense, Brussels, because you've been there with the Party of European Socialists quite some times, and now you are leading an important ministry side by side with the minister, and you are also witnessing what we discussed today, that health is a cross-cutting issue. So it's addressed we had a Minister of Education, now we touch with you the Minister from Digital Transition, floor to you with maybe a word on how you see health as a priority in your portfolio, and maybe a look at these the next European elections.
Well, by the habit, I would speak English, but as we are in Poland, and I'm representing the government, I don't know how many viewers we have and participants speaking Polish, how many English. If you don't mind, I will switch into Polish. Więc, proszę Państwa, bardzo mi miło, dziękuję za zaproszenie.
Ladies and gentlemen, thank you very much for inviting me here. What I would like to discuss here first is referring to one more aspect of healthcare, and this is digitalization. Because when we entered the ministry on the 13th of December, 2 days later, we presented our priorities. And out of three main things which were announced by the Deputy Prime Minister, the Minister of Digitalization, was digital hygiene. And this is one of our most important fields of action for this year. I don't know if you know that. I wouldn't like to bother you with figures. More than 30% of children between 4 and 9 years of age use smartphones. If we move to the group 10 to 15, it is more than 90%. What an entire, the plethora of things caused by the fact is that teachers and parents are not aware of. Obviously, it is the shifting of responsibility. Is it teachers, or is it parents, or is it government? But this should be the effort, collective effort of us all. There is a number of studies which say that the level of concentration is dropping because of the lack of digital hygiene. There was a number of students who are solving tasks, who are solving difficult tasks, and those who had their smartphones close to them had their results lower by 20% just because their smartphone was next to them. There are problems with attention span and also so-called fear of missing out. And this is something that I would like to stop on for a moment. Probably each of you selected how many hours a day you spent online. In case of teenagers, depending on the age group, it is 5 to 6 hours per day, almost as much as we spent at work, having a full-time job and obviously observing the work-life balance. But let's put it aside. Let's forget it. Try how many times you remove the blockade from your screen. And these numbers are frightening. So it might turn out that you spent 1 hour a day, but you checked your phone about 100 times. This shows the level of addiction. Try to check sitting in a group of family members, how many times you check your phone when watching TV. How much time are we? It's more difficult to concentrate for a long time on a book when a telephone is closer. At the ministry, we have a principle. So we leave our cell phones in boxes before entering the office of the Prime Minister, because this can guarantee that we'll listen to each other, because nobody checks their emails or other messages. Another thing is the digital mindfulness. If we are speaking about mental health, another issue is how we interact with other people. And also, I would like to tell you, to recommend you to an experiment that no phone can be on the table during a meal, a family meal. If it's not an emergency, the telephone can wait. At the start, it's not easy, but if you introduce it, the family relations look differently. We mentioned COVID many times. We have been made in such a way that we recognize emotions, looking at each other's faces. When people wore masks, it was more difficult, but when you look into your smartphone, it's also difficult. So another thing, another issue, which is by all means important, is what is carried by the telephone. It turns out that 40% underage users were had experienced some kind of persecution or hatred online. It could be mocking, it could be hatred, it could be calling names. But if 30% of young people experience that, 60% of parents are not aware of it, and they will claim that their children never experienced anything like that. And the studies reveal an increasing number of adolescents who have problems with saying, I'm fine, I'm good enough. When you are a teenager, it's always a difficult thing because you tend to compare yourself with others many times, but uncontrolled use of online services, especially social media, makes it worse. Last week we met Vera Jourova, the commissioner, who stresses the role in contemporary societies, because David, you asked me to refer to elections, the role of disinformation in elections. But one of the forms of disinformation is the spread of hatred, which demolishes societies, builds divisions, and creates untrue vision of what's going on in a society. Why do we speak about digital hygiene? Because we need to be aware that it's not only about good toys, because we need to build, and we're going to do it, that the algorithms use psychological mechanisms and they have specific objectives. It's like when you come back home. What do you do when you come back home? What do you do? Some people take off their shoes, some people don't, but you go to wash your hands. Why? This is our natural hygiene that you even don't think of. And you can say that digital hygiene should be like this. You come back home and put away your phone. Don't check your work messages. So don't check any messages from school. If there is another discussion on Messenger among teenagers, we need to talk about which direction we would like to follow and how important it is to keep the balance between the digital world and real world, because otherwise the degree of addiction of online services on telephones would lead to mental problems in social communication. If we do not wake up, we will have a huge scale to catch up. And this is one thing. Another issue, just a slogan, just a watchword to announce, we will start a very strong fight against pathological streaming. This is the curse of contemporary times. Awful things are being shown online, and people who do that earn, and children who are not aware of it, they watch it. Children and adolescents. So we are going to introduce legal solutions to resolve it, because this diverts gradually from the subject of the conference. To end with regards to digitalization, we wait for another discussion. The European Parliament adopted AI Act because there is still a strong debate about artificial intelligence. It's not about its effectiveness, but what it's going to serve, how it's going to serve us, which content should be communicated and how. Finally, whether artificial intelligence and new generations are going to serve us to make our lives easier, or perhaps our lives will be more difficult because we're going to lose our jobs. And this could be perhaps a separate panel for the discussion. You know very well that if people are afraid of losing their job because of technological progress, this might lead to a number of health consequences relating both to mental and physical health. So this is one of the challenges that we are facing, and the debate about the direction of artificial intelligence to develop. Digitalization. David, you wanted me to say more about politics and elections. Sometimes we do not appreciate it because we take it for granted that in Poland the previous opposition and now the ruling party has won the elections, because on the following day we had to start working, get down to work. But at conferences we would like to stress that this was by all means a great thing. First of all, because if we believe that if the previous authority was highly undemocratic, to put it mildly, there are studies that show that the third term of office of undemocratic authority will make the return to democracy very, very difficult, almost impossible. So we protected Polish democracy at the very last moment. We protected it because the ruling party made a lot of serious mistakes, that social processes and social unrest accumulated, but also because I believe that apart from that we managed to present the alternative, we managed to unify as the opposition. I know that it's a watchword repeated by politicians, let's get united, but we competed, but we didn't fight against each other. We said to each other, we are going to govern together. What is our point of action in Poland and Europe? In Poland, we are going to have 100 days of new government. In Poland, the new coalition still learns to collaborate with each other. In Poland, there is no tradition of 4 parties ruling together. If there were coalitions, there were 2 parties and not 4. But more parties require a lot of collaboration. It might seem that we quarrel, argue with each other a lot. It's not true. We are strong in verbalizing our standpoints. And there is still a huge work for us to do with regards to the restoration of the rule of law. It's an issue for another discussion panel. How to restore the rule of law, whether to respect the laws that have been implemented or whether to annul them, whether we should restore something that we fundamentally disagree with, believing that they violate the Polish constitution. These are the questions that the ruling team asks, but we want to be the country best protected against the violation of the rule of law, because we learned this with the example of the previous government. We realized how important it is to speak about democracy, what democracy is, because it is very easy to lose it. Another thing is the European context, the international one. And I believe that we speak about war in Ukraine too often. I believe that we talk about it too rarely. There is nothing in the war in Ukraine that you can get used to. We are seated together comfortably and talking about the things that have nothing to do with war. But one missile that drops on this side of the border would change completely our debate. This war is not far from us. It's close. People are dying. And let me repeat what all European and world leaders say. Russia must not win this war, because if it does, nothing will stop it. And other countries will dare to use what Russia does. That is power and terror. Are we talking about, whether we're talking about health or digitalization or other fields, we need to build social resilience. And we need to start a very serious debate here in Europe how much we can devote. Europe has a significant standard of social protection, and many societies don't want to speak about the war. How much we can sacrifice to avoid even a greater war. But the price that we pay today for avoiding the war by means of helping Ukraine and supporting our defense system is a very minor price compared to what we would have to pay if the war was waged in our territory. So facing political, military, health, digital challenges, what we are talking today, what we need to talk about, is our tendency to be more engaged, perhaps not to sacrifice anything, but to get more engaged, to give away some of our comfort, to guarantee the life that we have to future posterities, so that we should not give up what we have because the situation might force us to do so. That is why European debate, strengthening European relations are the priorities of this government. That is why we talk to our neighbors. That is why we return to the Weimar Triangle or the Visegrad Group, which is more difficult because of the political situation. And that is why also we restore what did not exist during the previous government, social dialogue. So authority must not tell the society what they should do because the authority knows better. 2 days before Christmas, it is not a good time for conferences because people think about something else. But we organize social consultation concerning digital challenges. So initially we said that we invite social organizations, and we rejected all companies. And then we said that at maximum there can be one representative per organizations, and still we had 300 people in our room. It was the largest conference before that gathered 24 organizations. We had 300, and there was a number of organizations complaining that they did not manage to squeeze in. So civil society wants to talk, but you need to provide framework for it and be able to listen to them. If we speak about disinformation, AI, and challenges, without social consultations, without dialogue, we are endangered with disinformation, disorganization, and further problems created instead of solving the current ones. I wouldn't like to talk too much, but I do hope that what we are going to do, I would like to promise, but I cannot promise. But I would like to say that what the Polish government, with the participation of the Third Road Civil Coalition and the Left Party, will be the good model to follow and not an example of what should be avoided. I hope that we have great regional responsibilities. People are watching us, and what is going to happen will be important for the whole region and the entire Europe. We are ready to take this responsibility. And this is what I would like to leave you with my great request to support us, but also to evaluate us, to tell us what matters, and not to be afraid to tell us when we are wrong, because nobody is free from mistakes. I promise that this is going to be a pro-European and pro-social government with an inclusion and not exclusion for citizens. Thank you very much for your attention.
In the Czech Republic, the Dashinsky Center here in Poland, but particularly the partners that help us in loco as well, Europa Patient and Critica Polityczna. Very, very big thanks. There might be space for one or two questions to our three distinguished guests. If you have, please come here. I'll give you the microphone so we extract the last bits of knowledge from them.
OK, thank you so much. Já budu mluvit česky, protože otázka je především asi...
I have a question to Director Nemeček. In this context, we spoke at the second panel because we have a problem about health services and their availability moves from regions to municipalities to cities, and it is a great problem in Hungary and in Poland, and I see it as a person who lives here, that people who moves from Chiniec to Ostrava, from Ostrava to Brno. So is there any simple, well, it's by no means simple, but is there any conceptual solution, social democratic solution, how to attract people, how to attract young healthcare workers to smaller towns to work for regions? And one more remark.
is really a mistake. I mean, public health has enormous significance, you know, in thinking, and I think it's important for all governments, and then in particular social democratic leaders, to take seriously the health at first should really be public, and we should not blame the victims or blame the citizens for ill health or whatever. So that's one thing. And then it relates to my second response, and you were talking about all the fake news, all the informations are spreading through the internet or digital tools, which of course are nothing to do, you know, with evidences, etc., etc. One thing what is really missing, and then in this regard, there is a responsibility for the European Union and also for the European Health Union. How to, I would say, improve the health literacy of the citizens and the public, because whether we talk about the schools, whether we talk about, you know, media broadcasts, so, you know, it's neglected in most part of Europe. That probably could be also one of the missing elements which should talk and should act much more.
Já tentokrát odpovím česky, abych se úplně vyjádřil přesně. Ta odpověď na tu otázku.
I'm going to speak Czech to be more accurate. Now, in Czech Republic, we need to bring back the force of social democratic movement and those who will deal with the problems. Thank you today for this inspiration from Poland. You have shown us that things can be done. And now let me come back to the core of the problem. In Czech Republic, we have an interesting situation, namely the healthcare agenda is not covered by politicians, but by experts from the biggest university centers. They decide where money will go and what priorities are. And their centers are the most important, and what happens in regions, well, they don't really care about it. So we need to bring this power back to social democrats, tell everybody that the public health is for people, and you can't have top level of services in 2 healthcare centers, and in other regions people won't be able to reach a dentist or a GP. And after today's meeting, I believe we're going to win. Well, how should I conclude? I wanted to say something about EU elections. Since we're talking about exclusion, about corporations and elections, well, European elections are ahead of us. And you're going to see what we see every time there's an election. There will be those who will try and divide us, who will try to scare us, tell lies about people being forced to eat bugs instead of meat, or those who talk about different substances being spread. You know, usually these are parties that are affiliated with those who are in the Red Square in Moscow. So let me appeal to you that we don't get foolish, that we don't get divided, that we don't look at the elections through the prism of what others want to scare us with, but with this vision of Europe built for everybody and not just for a few. Europe built on collaboration and not built out of fear. So we're going to be tested many times, tested with many instances of disinformation, but I trust that if there's true dialogue, if we appeal to society and people can read between the lines and see what propaganda brings, then the result of the elections will provide us with a European collaboration for the coming years. We cannot let people who wish to divide us and who don't want collaboration to win.
Today on Health for All, from a slogan to a reality for Europe. As you clearly understand, it will take a while to get it to become a reality for all Europeans, and the only way it can become a reality for all Europeans is that we continue working together from different countries. Here, just in this panel, we have Poland, Italy, Czech Republic, and Hungary. So let's see more of the progressive uniting to push forward for these important matters. It's a fight that we have to do together. The point of expanding and relaunching social dialogue in Poland is extremely promising. Thanks for bringing it to the attention of the group. It's the togetherness with the associations, patients, professionals that can help us having a stronger voice and a stronger legitimacy to act. So it's a long objective, but it's one that is worth pursuing. So let's stay together and remain connected on this and another matter. All the foundations are very active, so keep in touch.
And last sentence, as David cannot thank to himself, thank you, David, and thanks to Foundation of European Progressive Studies for gathering us, all of us here together.
Thank you, Conrad.